Welcome everybody. Welcome to today's Linkage Learning webinar. My name's Felicity Flack and I'm the Senior Manager Strategy and Services at the PHRN. I'm speaking to you today from the University of Western Australia, whose campus is situated on Noongar land. Noongar people remain the spiritual and cultural custodians of their land and continue to practice their values, languages, beliefs and knowledge. First of all, a little bit of housekeeping. If you've got any questions for today's speaker, please type them in the Q&A box at any time during the presentation. We'll answer as many questions as we can at the end of the presentation. This presentation is being recorded and we will make it available on the PHRN YouTube channel as soon as possible after the webinar. So, I'm delighted to introduce Professor Gita Mishra. He's the Professor of Life Course Epidemiology at the School of Public Health at the University of Queensland and also the Director of the Australian Longitudinal Study on Women's Health. We're very excited to have Gita back. She's talked to us before, but today she's going to talk to us about endometriosis, which I'm sure will be fascinating topic for everybody. And it's something that we've not covered before in this webinar series, so I think it will be particularly interesting from that point of view. So let's get started and I'll hand over to Gita. Thank you, Gita.
Thank you, Felicity. Let me share my screen. Okay. So, yeah, good morning, good afternoon, everyone. This morning, I'm going to talk about the epidemiology of endometriosis across the life course. I'm going to share with you some of the research that we are doing at the University of Queensland. Before I begin, I'd like to acknowledge the traditional owners of the land on which I'm speaking from, that is the Yagara and Turrbal people, and we pay our respects to their elders past, present, and emerging. So today, really what I'm going to do is to discuss about endometriosis, what it is, and how we've estimated the prevalence and incidence of endometriosis. I'm going to provide a little bit of background on the life course conceptual framework for endometriosis, and we will discuss the early life factors that could be associated with increasing the risk of endometriosis. And then I'm going to share with all of you some of our published work looking at the longitudinal association of endometriosis with health symptoms, quality of life, and so forth. And we'll conclude today's talk talking about current research and also future research plan. So to begin with, what is endometriosis? You would have heard, it's really in terms of the media, it's a hot topic. So endometriosis is an inflammatory disease where tissues that are similar to the linings of uterus grows outside it. So you can see from this diagram here, the endometriosis on the uterus, on the fallopian tubes, and so forth. So it commonly occurs on the ovaries, fallopian tubes, and peritoneums. The symptoms associated with endometriosis are chronic and recurring throughout a woman's life. So some of the common symptoms include severe pelvic pain, heavy menstrual bleeding, and also infertility. The thing about endometriosis is that there is a wide variations in clinical manifestation and symptoms. It is some of these endometrial tissues can even be found in the lungs. It can be found on the stomach, on the colon, and depending on where it sits, it can affect the level of pain a woman experiences. So there are also a group of women who've had endometriosis, but don't have the symptoms for it. So they're asymptomatic. And we can talk about them later. So the issue is that there's a lot of challenges in diagnosing endometriosis. It's only recently I would say in the last 5 years or so, there's been a lot more awareness. There's increase in social and professional awareness in terms of that. Social media has gone into it. Our papers, the government have been aware, has become aware of endometriosis. One of the things is that the issue with endometriosis is there's a lot of diagnostic delays. So for some women, it can take about 7 to 12 years before they've been diagnosed. And usually they've been diagnosed, say, in their peak, maybe in their peak, late 20s to early 30s. And for quite a few women, it's when they're trying to fall pregnant, and they have problems in falling pregnant. They go and see the doctors, and then they find out, oh, I have endometriosis. So that's usually how women are being diagnosed. The symptoms, the issue is that the symptoms mimic all other disorders. So for instance, irritable bowel syndromes, they may feel bloatedness, they may have, constipation. So these are such a ubiquitous symptom, so you can't really pin it down to it being associated with endometriosis. And as I mentioned before, the symptoms can also be asymptomatic. The women may not know that they have endometriosis. Now, the gold standard currently in terms of diagnosis of endometriosis is through surgery, so laparoscopy. So you can imagine that a lot of women may not want to do surgery for diagnosis, and that's another issue that causes the delay. But I must admit, for those of you who've been following the news recently, there's a group in Sydney now that are coming up with diagnosing using ultrasound and MRI. So we're looking into a more non-invasive method of diagnosis, and that's where a lot of energy is being put in at the moment. This is really looking at the disease from the life course perspective, and this is work done by Stacey Mishra. And you can see, for instance, on the y-axis here, for instance, this is achievements in life, education, and family and career. And these are on the x-axis, they're just different stages in life. The red line here, maybe I'll talk about the green line. So the green line here refers to accomplishment or achievements for women without who've not been diagnosed with endometriosis. So they don't have endometriosis. You can see that, that's just a trajectory across the life course. But the red line here, it really represents women with untreated symptomatic endometriosis. So, at every stage in their lives, it seems that they're not performing their best, or they are, having a lot of problems. So for instance, here you can see there's issues, a higher risk of difficulty in conceiving. They have, which I'll talk about later on, our data have shown issues with pregnancy complications, and also some results to share with you on what we're finding with respect to menopause. Now, up to, I would say, previous to 5 years ago or so forth, there was very limited data on the prevalence of endometriosis across the world. And in particular, we didn't have a very good data on the prevalence of endometriosis in Australia. A lot of time you will hear people say, 1 in 10 women been diagnosed with endometriosis, and that results really came from a very small US study, mid-US study done in the 1989. So what we really wanted to do, and the Australian government wanted to know, well, how big is this problem? And that's where we come in. So in 2018, the Australian government published its first National Action Plan on endometriosis. It was a 5-year plan. And I must say that it is the first in the world to have a National Action Plan for endometriosis. In 2022, 2 years ago, the French had their first endometriosis policy. And last year, Scotland the government also came up with a plan for endometriosis where they really want to reduce the time to diagnosis to 12 months. So for us here, for the National Action Plan for Endometriosis, there was three directions. One is awareness and education. And I think that in the last 5 years, we've done quite well in that space. Clinical care, at the moment, a lot of investment is being put into that. You'll be aware that the government has announced 22 endometriosis and pelvic pain clinics. And also the other direction of key direction is research, because there's a lot that we don't know about endometriosis. So 5 years on, I think we can say that there is work in progress. Not all the goals have been achieved, but substantial progress is being made in Australia. One of the thing that came out from the National Action Plan is really about trying to quantify or to discuss the prevalence of endometriosis. So part of the work that was done by our group in Queensland was to try and estimate the prevalence and incidence of endometriosis, and I'll talk about it in detail in a few minutes. So we worked closely with the Australian Institute of Health and Welfare to come up with the prevalence and incidence of endometriosis. This work that was done was published in 2021, and since then we've also updated it to the latest prevalence and incidence figure, and I'll go through that with you in a minute. So you would have heard me talking about last year about the Australian Longitudinal Study on Women's Health. As you know, that it is a study that's been funded by the Commonwealth Government Department of Health and Aged Care since 1996. It's still ongoing. The study is jointly run by the University of Queensland and also the University of Newcastle. Back in 1996, there were three cohorts of women were recruited, three aged cohort. But what I'm going to do is to talk about the two youngest cohort. So I'm going to talk about the cohort that was recruited in 1996, the youngest cohort then. They were born in 1973-78. And at that time, they were 18 to 23 years old. And currently they are in their late 40s to early 50s. This cohort was recruited entirely through the Medicare database, and what we did was they were oversampled. So women living in rural and remote areas were oversampled. Now, I think one of the things that, looking back, was amazing that in this cohort of women in the year 2000, that is 24 years ago, we asked them about endometriosis, and we asked them whether they've been diagnosed with endometriosis. So since then, we've been collecting data on self-report endometriosis, but also, I'll talk about later on, is linkage to the hospital and so forth. So that's one cohort that has given us a lot of insight into the etiology of endometriosis among Australian women. The other cohort that we've been doing is also in 2012, 2013. We recruited another group of young women aged 18 to 23. And now they're in their late 20s, early 30s. They were recruited entirely via open recruitment by social media or social media platforms. I can say that the women, the two youngest cohort that I'm going to talk about, they are all over Australia. So they're nationally represented. So I'm going to talk a little bit about how we actually started calculating the prevalence and the incidence of endometriosis. So this is a cohort in 73, 78, and you can see that the first wave of data, the baseline was in 1996. The last wave 9, it was done in 2021. And the 10th survey, it will be in the field next month. So these are the repeated survey that we have asked women about endometriosis back in 2000. The other strength of the study is really about the fact that we have linked administrative data sets. So there is we linked it with the National Death Index, mortality database, cancer registry. But for this particular project, we really did use data from the hospital and perinatal data sets, the MBS and PBS schemes. So, you know, all ALSH cohorts have linkage data. So what happened, the first thing we wanted to estimate the prevalence of endometriosis. We looked at data from multiple sources to try and triangulate the number of women or the prevalence of women with endometriosis. So we used their survey data, which was repeated, hospital data, and there is a hospital ICD code for endometriosis surgery. We also did look at their PBS data in the sense of looking for medication that's restricted for use for endometriosis case and MBS data. So using all these multiple data sources, we were able to estimate the prevalence of endometriosis, or rather the cumulative incidence. And what we showed is that by the age of, I would say before their 50th birthday, right? So by the age of 48, 1 in 7 women were diagnosed with endometriosis, and that's around 14%. If we looked at women in the cohort, the youngest cohort, the ones that were born in 89, 95, by their late 20s, around 1 in 11 women were already diagnosed with endometriosis. And so you can see here that our younger cohort, there's slightly higher prevalence of endometriosis compared to same-aged cohort, you know, who were born 17 years before. And that could just be that, you know, these women, the difference in prevalence could mean that either the younger cohort, more of them have that symptoms, or, which is not a good news, or it could also be that there's a lot more awareness in terms of by the women and their health professionals, so they're getting diagnosed earlier, which is not a bad news in that respect. The other thing, I guess, is, you know, when we were looking at this sort of figure, and while doing this work, looking at prevalence or cumulative incidence, it became very important that whenever we're presenting these statistics, to keep in mind what age are we talking about, you know. And you'll find that a lot of time, they tell you the prevalence, but they don't tell you the sample or the age at which you know, the prevalence applied to. So you can see from this graph quite clearly that if you're talking about women in their late 20s, for instance, you know, their prevalence is this, right? Around 8 or 10%. But if you're talking to women in their late 40s, the prevalence is higher. And I think that's so important to really keep in mind when we're talking about prevalence or incidence. What age group are we talking about? And looking at this, which age cohort are we talking about? So what we really wanted to do is, we have the data now on the prevalence or incidence, and we wanted to look and see what are the early life factors, what are the factors that can affect the risk of endometriosis. So this is a conceptual framework that we work on, and, you know, we did some literature review, which I'll share with you, but there've been work shown that about, you know, 50 to 60% of the etiology in endometriosis can be explained by genetic variants. There's also obviously one way of capturing that is family history. Some work has been done showing perhaps that could be some early life exposure or childhood factors that affects the prevalence of endometriosis. So this is the framework that we're currently working on and trying to quantify the association and relationships. This was an earlier work done by one of my students. We looked at early life factors for endometriosis. And can I say that the number of papers on this is really limited. You know, you're looking at, less than 20 papers being published in this topic. So it seems there's some evidence for low birth weight to be associated with the diagnosis of endometriosis later in life. But all the other factors, the results are really mixed. We can't really draw any conclusion for it, or there's limited evidence. So, for instance, there's things on preterm birth, but also in utero exposure to DES, maternal smoking. Some studies have found association with passive smoking in early life, but also with respect to infant formula feeding. But as I said, this is all mixed finding. There's not a lot of work done, and certainly not large-scale studies. So that's the sort of area that we'll be looking at, and I'll share that with you later on. The other thing also with respect to endometriosis is, there is some sort of idea that it could be related to endocrine disrupting chemicals. That's been shown to be associated with endometriosis. So we're looking at air pollution, water pollution, and so forth. Some of these association we can see, we can replicate it in ALSH. So that's interesting. Now, this is another angle that just came out last year that, saying perhaps it's the environment pollutant that might increase the risk. But again, there is not a lot of evidence, and we want to try and see whether our data can help shed some light onto this. So this work was done by my postdoc, Dereje, and so we started looking to see the association between endometriosis and some of the common symptoms. And you've seen this data. There's about 9 waves of data on, or 8 waves of data on endometriosis, and we started looking to see some of the common symptoms. So from the 1973-78 cohort, what we found at every survey, we're looking to see that women who've had endometriosis were more likely to be complaining back pain, joint pains, headaches. They were also more likely to be having menstrual problem. Now, this analysis was done longitudinally. So at every wave, we saw the association cross-sectionally, but also when we did the analysis longitudinally, it became even stronger. So they had menstrual problems, but this, like painful menstrual dysmenorrhea or painful periods, but also heavy menstrual problems, and more likely to report on that. Anxiety, depression. There was also bowel problems and constipation, and it's not surprising that they reported poor mental health. Also, inadequate sleep. So that's the issue, is that there's a lot of symptoms that is ubiquitous, that is associated with endometriosis. So that makes diagnosis quite difficult just based on symptoms. The other thing that we found that we were a bit not sure, we were surprised to see that women also reported low iron, women with endometriosis. So what we did was we started looking to see if we could adjust for their diet, but also we adjusted for heavy menstrual bleeding, because we thought there's evidence to show that women with endometriosis tend to have heavy menstrual bleeding. So we adjusted for that. It was still there that the association with low iron intake was quite strong. And that work has been published in another journal. So here, this is just another way of presenting the results, where you can see that, it's not really associated with leaking urine or skin problems, but then you start getting into the indigestion. They reported they have problems with their feet. There's breathing difficulties, and you can see that as you go down the list, the more stronger was the association. So severe period pain is known, like, to be associated with endometriosis, but urine that burns or stings, that's quite not really well documented, but we're seeing, even though the confidence interval is quite wide, nonetheless, the point estimate is still strong. To heavy menstrual bleeding is again well known to be associated with endometriosis. And then these are your bowel problems. You have severe tiredness, back pains, depression, and so forth. So you can see that women with endometriosis, these are the symptoms that co-occur with endometriosis. The other thing, then what we did was we looked to see whether what is the impact of endometriosis on the women's quality of life, and that's using SF36. Again, we have repeat measure on SF36 through across the 7, 8, 9 surveys. And it is not surprising, but again, there's very limited work but out there, so it's not surprising. So for those of you who don't know SF36, it has 8 dimensions or 8 domains. 4 of the domains tend to load heavily on the physical health, and the other 4 tend to load heavily on the mental aspect of quality of life. So in some ways, we were quite kind of relieved to see that the way we've ascertained endometriosis actually does correlate well with the bodily pain, the physical pain as well. So you can see it's strongly related with the bodily pain dimension of SF36. The general health is affected, the role physical is affected. And then these are more things that again, vitality, and this is after adjusting for a whole bunch of things. You still see that women who have endometriosis tend to have poorer quality of life, and that's evident from this piece of work. So I'm going to explain this slowly. First of all, let's look at the table. And here what we did was, as I mentioned before, that there's a whole bunch of endometriosis is associated with pregnancy complications. And our data actually show quite a strong relationship. So let's look at the 1973-78 cohort here. That you have this column is your control group. This is the women with endometriosis. And this is your youngest, the younger cohorts. And what you see is, and that's just percentage, you'll see that, for instance, 2 or more miscarriages, or you can call it recurrent miscarriage. Women with endometriosis, 16.4% of them reported that they had 2 or more miscarriages compared to the control, women without endometriosis. But look at the figure for the youngest cohort. So 5% of our women born in 89-95 report that they have 2 or more miscarriages compared to 1.7. So it's almost 2.5 times higher prevalence. If you look at PCOS, for instance, right? So again, in the youngest cohort, about in our population, 10 0.4% of women reported having endometriosis, or having, of the controls, have PCOS. Women with endometriosis diagnosis, 25% of them also had PCOS. So you can, again, see is double compared to the general population. We didn't ask the women in the youngest cohort about uterine or fibroids or uterine polyps, but you can see that in the 73, 78 cohort, again, that number is almost 3 times women with endometriosis reported having uterine polyps. This is the next one is gestational diabetes. Again, it's higher among women with endometriosis. If you look at gestational hypertension, higher. This is preterm birth, again, is high. And this one is giving birth. So this is them giving birth to a low birth weight baby. Again, it's higher. So what you can see is women with endometriosis tend to have, the co-occurrence of these gynae conditions, other gynae conditions, and pregnancy complications. So they are higher risk. One of the things that we take a lot of comfort with in the Australian Longitudinal Study of Women's Health is because you have 2 cohorts, you can see where there's consistency of results, and in some ways almost replication of results. So what we are seeing in this cohort, the 1973-78, we see the same sort of thing, if not even stronger and higher prevalence in the youngest cohort. So that gives us confidence in the results that we are getting. Some of these things are taken from the linked data. So in some, if you look at the summary here, what we're saying is women with endometriosis are more likely to experience 1 or more miscarriages. But I would say that they're more likely to experience recurrent miscarriages, because experiencing 1 miscarriage is quite common in the population. They're more likely to develop gestational diabetes, more likely to experience gestational hypertension. They have a baby that's low-born, preterm, or low birth weight. And also they're more likely to have PCOS or uterine fibroids or polyps. So that's kind of the summary of it. But what, looking at this sort of relationship also makes you think, that what we call symptoms of endometriosis, are they really symptoms of endometriosis, or could they be symptoms of some of these other conditions that go with endometriosis? So I think these are things to really think hard about, if we're thinking about the etiology of the conditions. So the other thing we have done, and, we're really fortunate to have the longitudinal study, is that we can kind of map the women's journey through the health system. So because if you remember, earlier on I mentioned that it can take about 7 to 10 years before women be diagnosed. So what we have done is using the hospital admission data sets, and also using NBS and all that, we can really start seeing women's pattern, when they start going to the doctors, what happens to them, and so forth. So this is the work that we are preparing for publication. And this is using what we've done here. It's on the y-axis is the general GP visits. On the x-axis, what we've done is we've regrouped where 0 here stands for time to diagnosis. So I want to see the women's journey before diagnosis and what happens after diagnosis, right? So on the x-axis, this is time at diagnosis. This is 3 years before diagnosis and so forth. And this is 3 years after diagnosis, 6 years after diagnosis, and so forth. Okay. So not surprising that at the time, around the time of diagnosis, you'll see that their visits to the doctors is quite high. right? So this dark line here, the solid line, represents women with endometriosis. And what we've also done is we've age matched and also matched by education attainment women in the longitudinal study who don't have endometriosis. So they're the control group. So once a control journey through the health system, and also the cases, so cases and controls. So what you'll see is that initially, before they were diagnosed, because remember the ALS study has been going now for almost 30 years, 28 years or so. So 21 years ago, before diagnosis, you can see the women with endometriosis, they had slightly higher GP visits. Even back then, before their diagnosis, it was still a lot. It was a bit higher than the general population, than, control group. And you can see it goes up to here. There's, about mean of about one visit higher. And then just, before diagnosis, and maybe their symptoms get worse, for whatever reason, they started seeing their GP more and more often. And you can see that before diagnosis, there's a rapid use of the health service. Okay, so then that's where it is, and probably get, surgery. Then what happens after diagnosis, right? And you can see that after diagnosis, the use, going to the GP service use, have gone down. So that hasn't gone up, so it has improved. So they're seeing their GPs less. That's gone down. But what was interesting is that it has not gone down to the same level as the control. So it's still higher than, it's still, much higher than the controls, but it's lower than where they were before diagnosis. So this is important because it shows that perhaps, they still have some symptoms, or they still have some issues. That's the GP use. Let's look at the specialist visit. And here what you see, again, it's not surprising. It's that up to this point here, no difference. Women with and without endometriosis. But, in the last 5 years or whatever, before diagnosis, there's a sharp increase in the mean specialist visit. So much so that before diagnosis was on average about 3 visits per year at that time. And then what happens after diagnosis, visits to specialists goes down quite a lot. So substantially after diagnosis, it does go down, and it keeps going down. But again, I would say that it doesn't reach the same level as the control. Again, it's pointing to, there are unresolved, resolved issues with women with endometriosis. This is something that I wanted to show is here you're seeing the mean obstetrician or gynecologist visit. And this is one case where there wasn't a lot of difference between the women with endometriosis and without endometriosis. But what you do find, and that's not surprising, is that women with endometriosis after diagnosis had higher visit to obstetrician and gynecologist. And we think that, one could assume that they're probably trying to either fall pregnant or start a family. And then it goes down. And there's no difference after 12 years between the two groups. So that is the sort of information that, is really going to help us understand what's happening in terms of health system and how they're progressing, their journey. And that's data comes entirely through the linked administrative data sets. So that's one aspect, and I just want to share with you what we doing currently. And in fact, this paper has been submitted. So I'm going to talk about menopause. And, the thing about endometriosis is that a lot of the attention are being placed on the here and now. So a lot of younger women will try and think about their symptoms, but most of them will come with issues with, 30% or 40% will have fertility issues. So that's what we're trying to deal with. But what happens to these women after their reproductive life? What happens to them? What happens to their health and well-being and all that? That's very limited evidence. And so that's another active area of research that we're currently doing. So I'm going to touch on menopause. Menopause is, again, you'll see it's been a lot in the literature, is out there in the media, and more recently the government has called for Senate inquiry into perimenopause and early menopause. So I'm going to talk a little bit about that. So what is menopause? It's really is defined by the permanent cessation of menstrual cycle. Usually the definition of age menopause is identified 12 months without periods. It occurs in the Western country. In Australia, the average age of menopause is between 51 to 52 years. That's the average age of menopause. It is important because it marks the end of women's reproductive life stage. And there's two things to understand when we're talking about menopause. One is natural menopause, where it's just a process of aging. Women, and as I mentioned, the average age of natural menopause is between 51, 52 years old in Australia. Some countries, some ethnic groups will have it earlier. So that's natural menopause. Nothing is done. That's just happens to everybody. The other one is surgical menopause. And this is when both ovaries are removed. Usually it could be a result of a cancer. So the women, when that happens, it's called bilateral oophorectomy, and the woman will experience menopause instantly. So that is surgical menopause. And then the other thing to know about menopause is, so for us, we think menopause is a marker of ovarian aging. It's a marker of our future health. And there's a lot of work that has been done to show that, women with earlier menopause have been shown to be associated with chronic conditions later in life. So I'm just saying associated. I'm not saying it's causes, and that's important. The other thing also when we're talking about menopause is the age. So premature menopause, that is, it happens to women before the age of 40. So if a woman has menopause before the age of 40, we say that she's had premature menopause. If it's between 40 to 44, we say that it's early menopause. So both premature and early menopause have been shown to be associated with chronic conditions later in life. So that's a little bit of background on that. So what happens to women who've had women with endometriosis? What's their reproductive aging looks like? Do we know, what's their age of natural menopause? What do we know about it? And you'll find that there's really limited literature on it, maybe one or two papers that mention that. So what we have done, and this work has just been submitted for publication, Lancet Public Health. And I'll just very quickly show you. So women can have a natural menopause or surgical menopause, so they're competing risk. Of course, we've removed women who are on hormones that we can't ascertain their menopausal status. They're not included. So this work comes from the Interlace Consortium, where we have over, almost 300,000 women from 5 observational studies in 4 countries. And what you see is that women who have endometriosis, they tend to have earlier, what you'll see here is that they're less likely to have natural menopause, okay? And this is what we're seeing. But they are almost 8 times more likely to have surgical menopause. Okay, so by the time they reach, they're more likely to have both their ovaries removed. And that is, I think, quite startling. I don't think that's been documented in that sense. And we've used competing risk with large numbers to show that. We have also been able to show that women with endometriosis, if they have natural menopause, they're more likely to have it early natural menopause than the rest of them. So they're more likely to have it around half a year earlier than the rest of the population. If the women with endometriosis, if they have surgical menopause, we know that they're at risk of surgical menopause, right? Around 8 times more likely. We also do know that they are 1.6 times, happens to them 1.6 years earlier than everybody else. So not only are they having surgical menopause, they're also having it at a younger age. And I think that's important because these things could affect her health and well-being going forward. So whereas with the natural menopause, they're less likely to have natural menopause, but if they do have natural menopause, they're more likely to get half a year earlier. And that's what we found. So what we're doing at the moment is really, there's a lot of gaps in the work in terms of the early life factors. So we've been funded by MRFF to conduct a study in ALSH women, and where we're looking at the genetic variants, early life factors, and also the longitudinal endometriosis symptoms to see if we can get a good hint of what's happening as before diagnosis, some of the earlier life factors. So very, very glad that we have around total with both cohorts, around 9,000 women have completed the survey. Quite a few of them have given us their sample. Now, out of the 9,000 women in both cohorts, I can say in total around 1,000 have endometriosis. So this results you see on your screen is really about women that have been diagnosed. So around 406 women in the 1989-95 cohort have been diagnosed. They're clinically confirmed to have endometriosis. And around 3.3% of them, we say they are suspected cases because, as I mentioned before, the gold standard for diagnosis is through laparoscopy. So these guys, they've been diagnosed by MRI or ultrasound or symptoms or the medication that's restricted for endometriosis. So, you can look, it's around 11% if you include both these categories. And these women are still quite young, as I put up there, by 30, age 30. And if you look at the younger group, the older group, there we had 514 women that has been diagnosed, confirmed to have endometriosis. And again, if you add these two numbers up from GAL study, that's almost about 15% of women, both confirmed and also the suspected case. So what we're trying to do next is we're putting together a team of us working on the risk calculator and just trying to figure, creating tools that will be helpful for the clinicians or GP. That is work in progress that we want to try and complete by next year, mid-next year. And that's about all, really. And I want to thank all my team based here at UQ, but also colleagues in Newcastle. Thank the Australian government. And of course, none of this work would have been possible without the generosity of the Australian long-term participants of the Australian long-term study of women's health. So really enormously indebted to their time and effort. The study. And if you want to hear more about us, we are hosting the 16th World Endometriosis Congress. It'll be in Sydney next year. Jason Abbott and I running the show. Please do come. And with that, also thank my wonderful group at the Australian Women's and Girls Health Research Centre at the university for all their support. And I think I take time for questions. Thank you.
Thank you, Gita. That was fascinating, and it's really encouraging to hear how much work you're doing on endometriosis. The women of Australia, thank you. So we've got a few questions in the Q&A, but if people have more questions to ask, feel free to add them to the Q&A box now. But let's start with the first one. Can you or did you look at women who had a laparoscopy for diagnosis who were then found to not have endometriosis?
I have to say that is such a good question because in part, see what happens is that in the GAL study, so they're a subset of the Australian Long-Term Study of Women's Health, right? So we were able to look at linked data, and they've, gone for laparoscopy due to endometriosis, So, okay, they're confirmed cases. And then when you come to the GAL survey, they said they don't have endometriosis. So a handful of them, not a lot to make a difference. A handful of them said that they didn't have the symptoms. And we think, huh? And so it could be that, through laparoscopy, through a further inspection, they didn't have it. So it is, yes, there is a very small number of women who, yeah, we have that.
Next question. Have you looked at early life factors associated with endometriosis, comparing asymptomatic versus symptomatic women?
No, because I have to admit that the GAL's data set, the study is just literally closed. We have all the data. We're still finalizing the data set, but very, very important question. And we'll certainly be looking at. So one of the things we will want to do is to quantify what % of women, because we don't know, we haven't done that yet. So what % of women don't have all those symptoms that we mentioned before, and then try and see, early life factors or some other factors, who are they, that sort of thing. I think it's so important, and it's really going to give us a good hint to what's happening. But if you ask me what % of women have no symptoms, I can't tell you, because we're still busy with the symptom stuff. But that is the next thing. Really good question, and definitely we will investigate that further. Yeah.
Do you think or know that the women with endometriosis are being advised by medical practitioners to have surgical menopause?
I don't know, I have to say, because the fact that the numbers are so high, the prevalence is so high, they don't get a chance to have natural menopause because it's happened a lot earlier, and all that. It could be, sometimes don't forget that the women themselves might want it, but I don't know whether they've been encouraged, or it could even be where the tissues are found. So if you find that the endometriosis, the tissue are found on the ovaries, perhaps, and they will have to remove it, right? So I can't tell what the professional, the health professional has said to the women. We don't know that, but what we do know is that it's a lot higher. Surgical menopause is what's happening to these women. And if we can avoid that, that would be great as well. We're thinking about.
And just a follow-up from me, do you have much data on endometriosis symptoms in menopausal women? once they...
Look, it's really interesting because in menopause, okay, so if you think about endometriosis, one of the key symptoms that keeps coming out is their menstrual symptoms, right? Heavy menstrual bleeding, painful periods. So we do know that during menopause, that it goes all over the shop for all women. The flow, it's inconsistent. Some women will experience heavy flow, some less. So this is general for general women. I think that for women with endometriosis, what's really interesting is to see whether they suffer or whether they experience more menopausal symptoms, such as hot flushes and night sweats. We haven't done that. It's not out there. So it's really like fascinating because there's a lot of things we don't really know. And so that is something we want to do, like, do they experience more hot flushes or night sweats? Or is it because it's nothing to do with endometriosis? It's just because women who have heavy menstrual bleeding period tend to have more menopausal symptoms. It could be that. It could be every woman with that characteristics have, or is it something special about women with endometriosis? So in terms of where we're going in the future, obviously we don't know much about their earlier life things. We want to try and kind of fit that jigsaw puzzle, but where they're going, after menopause, what happens to them, again, there's a lot of things we don't know, and we want to try and also understand that. So really taking that life course perspective and trying to figure
Very
it out.
complicated.
It is. It's complicated, but it's interesting because there's just so much we don't know, and like you still hear women were saying, oh, my doctor told me to get pregnant so that I won't have the pain of endometriosis. It will fix my endometriosis issues. You still hear women saying that, even though there's no evidence, and I don't think health professionals saying, I don't know. We don't know that, there is that belief, right? Some people still say that. So there's just so much to do in that space. And also, I think from our perspective, what the woman is going through, is it because of her endometriosis or is it because she has all these other symptoms? That's another thing that I want to try and really disentangle.
Okay, so last question, and I think it's actually quite a good last question. If you could use any kind of data, whether administrative or otherwise, for endometriosis research, what would it be? Sort of.
It's at the moment, I think where we're going with endometriosis is all holistic. So we have the qualitative data trying to understand women's experience, but also I think, genetic information is super important. The molecular data is important because we want to look at the signature of endometriosis. Of course, I didn't say that, you have stages of endometriosis, you have deep sites of endometriosis. So it is really complicated. We do need to get to the molecular level as well to try and understand. Obviously, we do a lot of health service use data, symptoms data. So I think it's all kinds of, everything fits in trying to understand endometriosis better.
Okay. Well, on that note, I'm going to say thank you so much, Gita, for that excellent talk. I'm sure everybody's going away knowing a lot more about endometriosis. And thank you to the Longitudinal Study as well, who have presented to us before and always give great presentations. So thank you once, and thank you to everybody who was listening in today. We will put the YouTube video up as soon as we have that ready. And so we'll leave it there today. Thank you very much.